bu oturumda da, ilk oturumda da biraz bahsetmiş olduğumuz haplarla kürtaj, medikal kürtaj ve teletıp meselelerini kürtaja erişim hakkı kapsamında biraz daha detaylı aslında dinliyor olacağız. Ben Ezel, Kadın İnsan Hakları Derneği'nden. Bu oturumda sevgili öncelikle Rodika Komendant'ı dinleyeceğiz. Rodika, Moldova Türkçesini artık söylemek durumundayım. Moldova Üreme Sağlığı Eğitim Merkezi'nden. Sonra sevgili Selma Hajri'yi dinleyeceğiz. Selma da Tunus Maramet'ten. Ve en son Women on Web'den, ki Women on Web bizim aynı zamanda proje partnerimiz biliyorsunuz. Veronica Fernandez'i dinliyor olacağız. Aslında İrem'de açılıştaki konuşmada bahsetmişti. 2021'de Mor Çatı ile birlikte Kadın İnsan Hakları olarak bir araştırma yapmıştık kürtaja ilişkin ve orada aslında görmüştük ki özellikle sağlık çalışanları, doktorlar bu haplarla kürtaj meselesine ilişkin hem bilgi sahibi değiller hem de ön yargılara, ciddi ön yargılara sahipler. Özellikle medikal kürtaj alanında çalışmaya, daha fazla bu alanda savunuculuk yapmaya ihtiyaç olduğunu keşfettik. Nitekim gerçekten de 2022 yılıydı. Selim'e bahsetti. CISI platformu, ki bizler de üyesiyiz, cinsel sağlık ve üreme sağlığı hakları platformu diye açabileceğimiz platformda bir Türkiye genelinde 6 bölgede bir araştırma yapmıştı. Ve 6 bölgede işte hekimlere, hemşirelere, sağlık çalışanlarına kürtaja ilişkin tutum soruları da yöneltmişlerdi. Ve burada medikal kürtaja ilişkin de sorular vardı. O araştırma internette mevcut, ilgilenenler bakabilirler çünkü gerçekten kapsamlı, bu denli kapsamlı son zamanların en kapsamlı araştırması bu konuda. Hekimlerin bazı bölgelerde %70-80'e varan oranda kürtajın zaten bir hak olmadığını iddia etmesi ve neredeyse tamamının medikal kürtajın kesinlikle yapılmaması gerektiği, işte güvensiz bir yöntem olduğu ve karşı oldukları, uygulamayacakları gibi tutum cevapları mesela o araştırmada da öne çıkıyor. Biz özellikle bu konferansta aslında, evet Türkiye'de durum böyle ama dünyada hiç de öyle değil. İlk oturumda da biraz girdik ama bu oturumda daha detaylıca gerçekten dünyada medikal kürtaja erişimde nerede duruyor? Bazı ülke spesifik örnekleri de konuşacağız. Ama globalde aslında biraz verilerle konuşa geleceğiz. Aslında ilk oturumda da Daniela anlatırken söylemişti, haplarla kürtaja geçildiğinde ölüm sayısı 0 diyerek. Hakikaten biraz daha buraları detaylı bir üstünden geçeceğiz. Şimdi ben daha fazla uzatmadan sözü Rodika'ya bırakacağım.
My name is Rodika Komendant. I'm coming from a very nearby country, Moldova. If you know, it's just flying over the sea, and you are in 1 hour in Moldova. Welcome. I am the founder and director of the organization called Reproductive Health Training Center, which in 2016 became a regional training center. We are training on how to develop evidence-based recommendations, guidances, clinical practices, guidebooks, and our focus has been always access to safe abortion. I am myself for exact 40 years an abortion provider, which came from doing DNC, then moved to vacuum aspiration abortion, and then moved to medical abortion. And I strongly believe that the future of abortion is women will determine themselves the gestational age, if they're pregnant or not, go to the pills, get correct information, get the pills, and have an abortion, even without coming to us, providers. So they will not care about systems, about protocols. Of course there should be some conditions respected. But I'm completely and strong believer this is the future of abortion. And all of us are here to contribute to this. I do not mention this because I was looking for WHO publications since the first one, if you remember, in 2004. And maybe at that time it was a little bit too technical having more technical recommendations on dosages, how to proceed in one way or another. But during the time, and I'm very glad about this movement, they also became more feminist, I can say, and more open to women needs. And the latest publication, and you see here in purple, I didn't put it in my slide, but they have excellent conceptual framework where not provider is in the center of this figure, but women. Women, or they say any pregnant person. So this person is in center of everything. All the system of service delivery, policy, I don't know, advocacy measures and things like this. So I was glad to see this once again emphasizing that abortion is an essential care service. And it was very important in 2020 when they first said this when pandemic started, when they published the self-care guidance, and they recommended to all of us to use non-surgical methods, to start use telemedicine. And it was before even they said this in 2022 in their guidance. So it's a safe, effective, non-complex healthcare intervention, should not be regulated differently to other forms of healthcare, such as regulated under criminal law. When unavailable and or legally restricted, women and girls risk resorting to unsafe abortion, of course. And in 2022, when they published this latest guideline, which is abortion care guideline, they said everything what we said earlier should be forgotten somehow. So please use this latest recommendation. And I want to take you through some of them, which in my opinion, they are the most important first. Second, recommendations which we have used in my region, in my country, in our entire region, 12 countries which came and became independent countries when Soviet Union separated in these 12 countries. And we are united by very similar abortion law, which I mentioned later. We are very united by the fact we are, all of us are speaking Russian, and the situation is more or less similar. This is why it's quite effective way to communicate and to work in the entire region, we as a regional training center. So, my favorite recommendations, which we don't know how to approach yet. And when I asked first our colleagues from WHO, Karen Kim particularly, she said, approach the entire recommendations from 2022 from the ones they are easier for you. And these are not easy for us yet. Clinical were easier for us. But this recommendation, we need to look on them because they can become very good advocacy tools. I don't know in your country, but in our region, in my country particularly, all of the ministries of health are looking for advice and guidance from WHO. So pay attention. I like this. So WHO recommends full decriminalization of abortion. Nice. Then recommend against laws and other regulations that restrict abortion by grounds. So abortion should be available on request on the woman, girl, or other pregnant person. Doesn't matter which gestational age this person has. So no matter, and I'm very curious, maybe Selma or somebody else can explain me from where this gestational limit at 12 came. Because it doesn't have any sense for me as an abortion provider. Doesn't have any sense. Because it's completely equal. 10, 12, or 14, yeah, with using specific recommendation is the safe. And when you don't do any more vacuum aspiration, somebody asked about 14 weeks. You can combine, you do medical preparation of the cervix, and then you do the vacuum aspiration, and then later you do dilation evacuation as a surgical method. So yeah, all women should have access to abortion, doesn't matter which gestational age. Then recommend against mandatory waiting periods for abortion. And there are countries, even in my region, like Georgia, which still have this 1 week they're having. Not talking about Turkmenistan, which it's a mess because in their latest abortion legislation they said 5 weeks. Only up to 5 weeks. It's nothing. Women at 5 weeks don't know if they're pregnant yet, many of them, and many other barriers. So again, remove third-party authorization for abortion. So spousal consent or even parental consent, like France, congratulations. They remove completely these requirements to have parental consent. Yeah, it's a way. In my country, it's 16, but still there are problems around this. And WHO, of course, comment on this. So they are not against the fact that the girl should be together with the parents in this difficult decision. But if the parents are completely against and this causes troubles to this girl, of course, system should be in place to help this girl. Then remove restrictions on healthcare providers providing abortion services. In the entire region from where I'm coming, only OB-GYN can provide abortion services, which is completely stupid. France, family doctors are completely allowed to provide abortion care, and which is great, or nurses or midwives, yeah. Then again, regulate conscientious objections and healthcare provider refusal. How many times we have heard this, that certain clinics do not provide abortion care because the director is anti-choice. So you see entire set of very good policy law recommendations which came from WHO. Then another recommendation which helped us in implementing telemedicine medical abortion was the recommendation where and how to provide abortion services. And I remember very well the previous guidance which said primary level of care. But today, WHO goes further and says there is no one recommendation where to provide abortion care. Different ways to service provision can be used, how to satisfy the needs of pregnant woman, girl, or pregnant person. And it's up to their choice. It's up to their preferences and needs, depending on the available resources and the national and local context, which is great. Things we're looking for, and remember I said my vision for the future. So this is like the first foundation steps to do this. Self-management of medical abortion. So the completely new recommendation for medical abortion less than 12 weeks, but pay attention, using the combination of mifepristone plus misoprostol or using misoprostol alone. Recommend the option of self-management of the medical abortion process in whole or any of the three component parts of the process. Self-assessment of eligibility, which everybody knows. And there are studies showing that women without any ultrasound know very well how many weeks they are having. Maybe a few of them having not regular cycle and things like this may be confused, but majority of them, all women are smart enough to know this. Then second, self-administration of abortion medication outside of healthcare facility and without the direct supervision of a trained health worker, and management of the abortion process. We're taking pills entire life from the childhood. Why should we invite women to sit in front of us to give her the pill to swallow? Doesn't have any sense. Self-assessment of the success of the abortion. Of course, and believe me, I'm an abortion provider working with medical abortion since 2003, when we've been trained in France by Daniel Hassoun, my mentor and teacher. Believe me, when we are calling and talking to women, just at the second day after the abortion, all of them, almost all of them know if they have had successful medical abortion, believe me. This is true, with rare exceptions. I would like to share with you what we did in 2019 to 2021. In 2019, and I'll show you the context in Moldova, to approach telemedicine even without having yet the WHO recommendation for us, it was like next logical step. Having quite large network of health facilities, having medical abortion pills in the pharmacies, sometimes over the counter, and we do have this confirmation that women can go to the pharmacy having the pills, and we're using Medabon, this combination of mifepristone and 4 of misoprostol, which is very logical and easily to understand how to take these pills. Then abortion is legal up to 12 weeks, and not only in Moldova but the entire region. After 12 weeks in Moldova, we managed to have a long list of so-called social indications to second trimester abortion. In some countries not so broad, and of course medical indications allow women to have pregnancy termination until the end of the pregnancy. What else? And this is again a confirmation like Argentinian case, but we have legal abortion since I was a child. Don't forget, it's more than 60 years. But look, when you have normal abortion here, what's happening with the abortion situation? It's becoming less and less, and today we have like 11 to 1,000 women, which is, the rate is similar to France, similar to European level. Okay, it's not like Norway, 8 to 1,000, but it's still dropping down. Then we don't have maternal mortality, and I forgot when we had the last one. Abortion complications, very low, 0.6, not very serious complications. So we don't see any more serious perforations or serious complications when women are losing their health because of this, you see. I didn't put here, but adolescent pregnancy is less and less, especially the proportion of adolescents having abortion. We still have quite big number of adolescents having kids, having child, but abortion less and less. What else? We became very good on this, and today me and my colleagues are trainers on medical abortion, trainers on manual aspiration, and we can talk to anybody, answer to all the questions. So it's how we put the foundation on next step, as I said, abortion via telemedicine. It was logical. Why? Because women in rural area, adolescents, they need to travel to the OB/GYN in the center of this region to have an abortion, which is stupid. Why not? Why they cannot have the pills at home, having the guidance from the provider and having a safe abortion? When we started in 2020, exactly when the pandemic started, we didn't plan this. It was by synchronicity, you know, and it was amazing because all the abortion clinics were closed down, and we launched the service immediately by coincidence, even in March 2020. Before that, we prepared the website, and we can see how it looks like. Women can assess their gestational age, and not only they can determine if they are eligible or not. Then they send us their contact data, only name and telephone number. Then the abortion provider is calling. They're getting the package with the pills, with the home guidance, step by step, what to do, how to do. Then she takes the pills. 1 week later, again the provider is getting in touch with her, ask specific questions, 3 or 4, not a lot. Know that she is okay, and then 3 weeks later she is taking at home pregnancy test, and this is it. And I remember a lot of phrases from women saying, "Oh my God, I couldn't imagine that abortion can come to my house," they say. Or there were regions where only cars taking some products, some bread and something else in the closed regions, and the post with our packages we're very proud about. The results, we have analyzed the data very carefully by using this database. It's not so important, but when we were asking why the participants have chosen this way of services, and surprisingly they didn't answer because we were afraid of infection, but majority of them said because it was convenient and it was confidential. And it means what our clients are waiting from us. They want confidential and comfortable services, most of them. The flow, so more than 500 participants participated. Don't pay attention to these very small letters. The most important is, so we were aiming to collect 200 cases in 1 year because of pandemic helped us, and we collected almost 3 times more. And the success was amazing, 98% of abortion, incomplete abortion very low, just 1.2%, and continuing pregnancy 0.8%. And it is exactly what we can expect from a country or from the services which implement telemedicine or telehealth or abortion the distance, medical abortion the distance. So and it is similar to any medical abortion. Very high efficacy rate, very low incomplete abortion, and very low level of complication. And it's similar, there is no medical abortion Turkish version or Moldovan version or French version. All of these medical abortion are similar, efficient, safe, convenient, confidential, and many other good things about abortion generally and about medical abortion via telemedicine as well. What they say, more than 99% very satisfied, and for the future, majority of them, of course, would like to have abortion at the distance or telehealth medical abortion. We published this in international journal, and 1 week before coming here, I received a mentioning how many thousands of times this publication was accessed by others and taken into consideration, which is very good. It's very difficult, by the way, to publish something in the international journals. And that time, Ministry of Health was very supporting. Why? Because at the beginning of the pandemic, journalists were coming to them asking, okay, now we close down all the clinics. What are you going to do next? And Ministry of Health was saying with proudness, we have medical abortion via telemedicine. But situation has changed. Well, in August 2020, they approved, in 2020, same year, they approved, and we worked on this, on the updated standards on abortion care, and they included without any questions medical abortion via telemedicine and the national protocol, national abortion standards. But government changes, change, and when the new government came in December 2024, because of the anti-choice petition and because it's an election year, they were threatening Ministry of Health, they sent petitions to everywhere, calling women irresponsible, stupid, all this stuff, this wording from them. And Ministry of Health, unfortunately, didn't follow our advice as experts, and they decided to ban or to stop temporarily medical abortion via telemedicine. Well, there were a lot of protests, a lot of requests from international organizations, from our local organization to install it back. We're still continuing, and it is a working group right now working on this, and again emphasizing the need for medical abortion, not talking about the fact that in August this year, 2025, Ministry of Health approved the national program on digitalization of services. And it's completely illogical. So you ban telemedicine for medical abortion and you install the program, national program. So we're optimistic. I think we'll manage to have it back. But right now I'm doing medical abortion via telemedicine to 2 Moldovan women, one in Germany and one in Italy. So who can stop this? Who can stop me? I know the method, I know it's safe, it's women need. Why should I follow to this anti-choice Ministry of Health? Okay, next. I like tasting everything in my country, and then when we taste it, it's good. We proposed to colleagues in Armenia, Azerbaijan, Kazakhstan, Kyrgyzstan, Uzbekistan to follow what we did. How? We started by questioning what think women, NGOs, abortion providers, policymakers, and pharmacists, by the way, what they are thinking about telemedicine medical abortion, because nobody has done this. We are talking about, but we don't know this group's opinion. And we conducted formative research supported by GCC options from Canada. And yes, interesting that the most supportive, of course, were women, brave, smart, all of them, all of us. They said, yes, we manage, yes, we want this. Majority of them said, yeah, first of all, look, we asked about the barriers to abortion care. For example, this is the example from Kyrgyzstan. And of course they said it's too extensive, too many laboratory tests, too many in-person visits, too far to travel. So you see, they are very similar to what we heard in the morning. I don't mention this, the provider's attitude, which is very much similar. So many providers are still not supportive. And women's opinion on self-managed abortion in Uzbekistan, another country, but answers are very similar. They are able to manage one or majority of abortion steps, no problems. And providers' opinion on implementing telemedicine in 5 countries, they are a little bit more reluctant, but still, to have it in country, they said we need to do regulatory changes, inclusion in national guidelines, we need to advocate, we need to have trainings. And the main findings of the formative research for 5 countries. So the barriers, multiple in-person visits, as I mentioned, access very limited or at all impossible during COVID, funding, substantial proportion of respondents place high degree of importance of introducing telemedicine in the countries, as it will contribute to better access to the procedure. And everywhere, the current telecommunication infrastructure fully allows implemented telemedicine services. In conclusions, I said, first of all, a campaign educating and communicating for women what's medical abortion in general and the details of the telemedicine procedure, widespread effort to train more providers, and regulatory changes. The most promising countries among those 5 was Kyrgyzstan. We conducted a similar pilot study, less number, just 100, but it was in 2 regions, Bishkek, which is capital region, and one is far away, Jalalabad. And look, the same very high efficacy rate, 97, just 3 manual local aspiration because of the bleeding. And the most important, after we discussed, because it was like this, approval of the pilot study, training providers, the pilot study itself, and then disseminating the information, and some policy level conclusions. And when we reported to the Ministry of Health, it was the order, and the working group was created to update the national protocol, and it was the telemedicine medical abortion, it's included in Kyrgyzstan, and I'll show you later which other countries. And the same what women think about the telemedicine pilot study in the services. Again, see, convenience and confidentiality. They didn't have to find somebody to provide childcare, few visits. You see the high level of satisfaction everywhere. Sorry. Well, in summary, so in Moldova, I reported to you what we've done. In Kyrgyzstan too. The same happened in Kazakhstan, interesting country. They updated their national protocol exactly in 2022 on WHO published their guidance, and they included telemedicine without any pilot study. They are now ready to conduct a pilot study just to enable more providers to do this. Then another region in Moldova, which is we called post-conflict, also very good success. In Armenia, they managed to review the legislation to allow medical abortion at the ambulatory level, and they did the protocol revision. We're not very happy. They are not very well following WHO recommendations, but anyhow, it's in advanced. And the training of trainers is planned for next year. And the Genuity Health Project, I'm sure you heard about this organization, they conducted themselves pilot studies in Azerbaijan, Ukraine, Uzbekistan, and in Ukraine and Uzbekistan, protocol revision is in process, meaning they are looking to include also this chapter, telemedicine for medical abortion. So to conclude, I mentioned this many times, we need first of all to how WHO put women in center of our efforts. I think the same. Women need to know better what does it mean medical abortion generally, how to get the pills. The pills should be qualitative pills. Women should know their rights. They should know exactly how to do the procedure themselves. And I was present in many feminist conferences like this one. I am you probably understood, a person, action-oriented person. So for me, it's very important to have a source of good qualitative appeal in the country, to have a good lawyer nearby, to be able to avoid all the troubles and unpleasant moments. Women should know very well where to get. Do you remember this harm reduction model which Leonel Briozo conducted long time ago in Latin America, which worked perfectly? So I tell to women everything, entire information. I just don't tell where she go to tell the pills. But coming out from the clinic, she knows from the other women where to get the pills. So I'm looking for this kind of actions, which is much more concrete and much more helpful to women. But of course, all your advocacy efforts are very, very important. And I would love to see here more providers in this room, because providers trainings, and it's very important that we need to have more providers on our side, because they are probably the most efficient advocates. Ministries of Health are listening to them. And of course, we are looking for regulatory changes which will allow all this to happen. And I'm sure, as I told you, that earlier or later, abortion will be in women's hands. This is the logical next step. Thank you.
Good luck Radika mücadelenizde 2024 sonrası yasaklı ilişkin bol şans. Uluslararası anlamda da Türkiye'den feministler olarak da size bol şans ve dayanışma dileklerimizi gönderiyoruz. Ama istatistikler ortada, kadınların ne söylediği ortada ama hala regülasyon konusu olmaya tabii ki devam ediyor. Bunu galiba değerlendirme oturumunda da zaten değerlendiriyor olacağız. Neden devletler bu kadar meraklı bu regülasyonlara, hukukla, kanunla düzenlemeye tüm bu araçları. Şimdi Selma ile devam edeceğiz. Sana pointer uzatacağım.
I'm really thankful for this invitation. I'm really very happy to be back in Istanbul after a few years. I am very happy and thank you for this. I mean, WWHR has really put people together, making this event an exchange of experiences and also of collaboration, and I hope more deep and more straight collaboration. I'm going to talk about Tunisia, and I will start first with my experience as a Radika. I am a doctor, but I am not a gynecologist. I came to reproductive health very, I don't know how, in fact, I can say. So, I was first involved in reproductive health and family planning, and then I started interested by the medical abortion, by the pills, and tried to introduce it in Tunisia. And it was in the end of the 90s. At that time, abortion was in a lune de miel, as we say in French. It's really the best period of abortion legal and available in Tunisia. In fact, in Tunisia, it started in 2093 by the new law that is part of the personal status code in Tunisia, and it makes abortion legal and available up to 14 weeks of amenorrhea. This includes all major women, married or unmarried, until the age of 18 today. It was at the time at 20 years. And they don't need any authorization of male. It could be the father or the married or the spouse of anybody. Beyond these limits, it's only permitted if there are specific circumstances, and you know this is what's called therapeutic abortion. Outside these conditions, of course, abortion is still criminalized under the penal code. So the abortion law was still the same law. It had been changed, abrogated with this condition. And this means that if one day they want to change the law, they can abrogate it So it's still, this is the dangers of the criminalization of the law for or against abortion. In Tunisia, what was specific to Tunisia is that in the same time they developed a family planning organ which was dedicated to abortion and contraception. And women, whatever they come from, have the possibility to access contraception and abortion freely without paying any billings when they want. Family plannings clinics provide abortion until 8 weeks only. But they are always very connected with the hospitals. So when the woman has a pregnancy more than 8 weeks, it goes to the hospital and is still free in the public sector. And in private sector, it's completely available. This has been the situation during years, and we were very proud of the situation, and I remember years and years presenting the experience of Tunisia as exemplary experience. Unfortunately, the things started to change around the end of the 90s and the beginning of the 20th years with the growing Islamic effect and the apparition of the media, like you know that, like Jazeera and equivalents, and this very conservative information through the media changed the mentalities. And at that time, we started to see a change in the attitudes of providers. Not only doctors, but also midwives. What I have to say that for medical abortion, which was introduced at that time, we rapidly switches the responsibility of providing the medical abortion to the midwives. So in that situation, midwives have the total control of abortion by the medical procedure. They also have the responsibility to explain how to use, and they do it, and they still do it very well. But they also, with the change of the mentality, they started to be they put more obstacles, they started to be more negative, with more negative attitudes. But the doctors are even worse, because the doctors started to be objection of consciences in all cases. We have seen with the presentation of Véronique that even in France, the doctors, usually the gynecologists, think that it's not their duty to make abortion. It's more their duty to make give birth, and treat, make surgical intervention for women. So this was the situation, and what we have seen is very quick progression of the quality of the service for abortion in Tunisia. Although medical abortion was the main method developed in the country. And this is related really to the regression of the Islamic influence, due to the Islamic influence, but also of the political regression on the responsibilities of the state and the government to provide abortion as a legal right for women. So we have seen large disparities appearing after 2010 with intra-regional and inter-regional disparity. And we have seen that it's, even if it's easier to have abortion in the big centers, in the urban and peri-rural area, it started to be more and more challenging. And there are limited staff, limited availability of medications, and also difficulties to refer. Yes. Difficulties to refer to the services and the facilities who have medical abortion. And this has been shown by studies that we made in our organization, which is the group Tawhid al-Sheikh in Tunisia. We have seen in 2019 that among half of the young people do not know that abortion is legal during the first trimester in Tunisia, which is completely crazy. And more recently, in 2023, A survey conducted by the same group have shown that only 26.6% of the men and 45% of the women were aware of the current law on abortion, which is really something incredible. And a larger proportion of them were either uncertain or did not provide any answer about the availability and the legacy of abortion. So conversely, barriers such as long distance to clinics, fragmented or unclear information, inconsistent service readiness make it harder for people in some regions, but even in almost all the regions today, to obtain timely and safe care for abortion. In all the regions of the Arab world, what you call Arab world, and Africa, in all the region, abortion is almost illegal. And even if there are some indications, like in Morocco or Nigeria, and surprisingly in Saudi Arabia, in reality, it's not at all available. So the region is very, very resistant. Nothing has changed until today. No one had changed any single word in the law. So, except Tunisia and Turkey, in all this region, abortion is illegal. And this made Tunisia really an exception. It's always also an exception in the African region, but in the African things are changing, particularly in Ethiopia, in Mozambique, even in Kenya, in Benin now it's completely available. Or Africa is very close to our region, but in the Arabic world, it's very difficult to change anything today. No. So when you see the world, you see that still today, nothing is changing, but the green part in the world is more and more important. And you see that in Latin America, several countries have completely changed the situation of abortion and the access of abortion. So what we can say now, that the landscape of abortion rights and access varies considerably across the Mediterranean regions, reflecting the diversity of legal contexts and health systems. Whether in countries where progressive abortion laws or countries with restrictive laws and policies limiting access to abortion, the issue of abortion remains deeply controversial in the Mediterranean regions, particularly on the southern shore, but also on the northern shore, where several countries now are conservative and have recently switched to become more and more conservative with the populist politics. Conservatism and populism are the dominant political trends today, and religion is used as an unassailable, argument to restrict women's rights in a highly patriarchal environment. In the Middle East and North Africa, sexual and reproductive rights, including abortion, even when presented as an unspoken right of women, remains inaccessible in almost all countries of the region. And it's still, as I told you, the only region of the world where laws have not changed since independence. When you look to the reason of that, perhaps we think that it's because the right to abortion is closely linked to the taboo on women's sex and sexuality. The denial of women's right to fulfilling sexuality that is not controlled by male's decision is strongly linked to the male domination and patriarchy. As elsewhere in the MENA region, very few feminist organizations are able to speak freely on this subject of abortion and include it in their advocacy for women's bodily autonomy. And we see that even in Tunisia, where we feel that there is a certain relative, like in Turkey, autonomy and freedom for speaking and for women's battles, still abortion is not a feminist cause. And this is probably due to mostly of the prohibiting laws in this country, as in Algeria, in Lebanon, and other countries of the region where even talking or Making comments on abortion is forbidden by the law, and you can be imprisoned for that reasons. It's also because it assumes that motherhood is not the only purpose of sexual reproduction relation for women, and that access to contraception outside the marriage is recognition of forbidden sexual relationships for unmarried young girls. The third reason is that abortion continues to be considered a shameful situation, rejected by the society. Even in Tunisia, where abortion law has existed for more than 50 years now, and SHRH services are legally accessible, the same obstacles to women's liberation and access to gender equality are still present. In practice, however, enforcement remains uneven. While the legal framework is strong, access is often undermined in Tunisia by limited facility availabilities, inconsistent providers' willingness, logistical and supply gaps, and the persistent weight of social stigma. Challenges that our organization, the Group Tawhida, seeks to address through advocacy, training, and capacity building. So what I can say is that for Tunisia, the Code du Statut Personnel has been a tree hiding the forest, a symbol of emancipation, but in reality, it's a text frozen for 70 years, unable of meeting the current needs today of the Tunisian woman. It's the combined weight of the religion, customs, political cowardice also, and the absence of widespread popular mobilization that could explain this inertia, that make the difference perhaps to the Latin American continent. These last 10 years, for me and for my group of providers and people fighting for the right to abortion, it was obvious that the question of barriers and regressions of women's rights was a regional trend related to religion and patriarchy. For that, we started on the early 20s to build a regional network for abortion rights and access with collaborators and experts from the Middle East region. This experience started in 2019 with a regional network for the MENA region on advocacy for abortion. It was created and hosted in Tunisia by this organization, the Tunisian organization, who work on sexual and reproductive health. Unfortunately, it started with the start of the COVID pandemic, and it was very difficult to work in these conditions. And also the lack of freedom to develop and expand our visions, let us try another model for the development of a movement with an enrichment of our community by inclusion of other Mediterranean countries from the North Shore. In this context of increasing conservatism and the backlash of the women's rights all over the world, we created in 2023 this organization, which is called Maramed. So Maramed is a movement that was reproducing this idea that a regional network that had been developed this morning, and we start to talk about it now for the region, that a regional network is an absolute necessity to fight all together and to talk more about abortion rights. The first event was in France, and it's symbolic that it was in France, and it's still, the movement is hosted in France because it's easier to work all over the world when you are in an European country, unfortunately. And this movement now is a regional movement on health and human rights, which is putting together activists committed to supporting safe abortion in the Mediterranean region and building a dynamic cross-sectional network of advocates. At Maramed, we focus on feminist approaches, learning and capacity building across the region, emphasizing grassroots activities and political openings toward wider support and recognition of access to abortion as a fundamental human right for women in the Mediterranean region. As part of a global network of global advocates, we strive to share and learn from other regional feminist movements and efforts to extend abortion rights and access in our region. Our mission and vision is based on these guiding principles to promote access to safe abortion for all women as a fundamental health priority and an inalienable human rights. These principles are the right to abortion, that implies a respect of women's fundamental rights, which must be granted and protected. And the right to abortion is cross-cutting and implies women's freedom to dispose of their bodies, to respect their physical integrity, and to choose freely. The recognition that restrictions, prohibitions, or criminalization of abortion and all other obstacles to its access must be removed, as they only endanger women's life and violate their fundamental rights, including the rights to life, the right to determine if and when to have children, and the right to privacy, the right to bodily integrity, among others. The urgent need for evidence-based approach to abortion access and best practice worldwide, and to counteract the silence surrounding abortion due to political, social, and religious pressures that discriminates against women and prevents them from leading healthy and fulfilling lives. The feminist approach for empowering women and girls must recognize the value of sexual and reproductive health and rights, including safe abortion. We aim to build this dialogue between the roles of the Mediterranean and beyond Mediterranean. The Mediterranean is a meeting point of diverse legal, cultural, and political regimes governing sexuality, reproduction, and care. While abortion is legal in some northern countries, it remains highly restricted in much of the North African and part of the southern and eastern Europe. Rising authoritarianism and restricting space for civil society further shape people's access to accurate information and safe care. Bodily autonomy, the right to make decisions about one's own body, sexuality and reproduction, sits at the core of the feminist struggles. Yet it is increasingly undermined by shrinking civic space, surveillance, platform censorship, and backlash against women's rights and gender equality. Mohammed aimed to create a cross-border feminist space for strategizing around bodily autonomy, abortion rights and access, and focusing on how movements in the Mediterranean regions can resist restrictive forces, build solidarities, and advocate for care-centered, right-affirmance and feminist approach to abortion care. Since several years, concerning the feminist implication and the feminism for SHRH, we are working on two domains. First, to make feminists aware that behind the right of abortion, there are also social and economic issues at stake, and it's not the social and economic issue that will resolve the question of access and right to abortion. Even in countries where these rights are recognized, they are regularly challenged and contested, both nationally and internationally, and are strongly denied in conservative countries. Nowhere are they fully granted. This is why it's essential to unite in the struggle. It is essential to integrate the feminist approach into advocacy for abortion rights, clearly highlighting the arguments of bodily autonomy and women's right to make their own decision about their bodies and reproductive lives. What are the signs of change in the region? Because there are positive signs, fortunately, because even though we will stay at home and stop everything. There are, fortunately, the new social media are probably changing the context. And they are also changing mentalities, at least for the young generation. Young people are now using social media as a direct channel of communication between young population, and they are changing attitudes toward taboos and secrecy by expressing themselves freely and discussing all aspects of sexuality without being judged. And we see new fora, new organizations like the Sex Talk Arabic, which is an Egyptian digital feminist collective working on cultural and cognitive empowerment in Arab society, like Kif Mama Kif Baba, which is a Moroccan organization who is fighting for the gender equality and justice, and now highly involved in abortion rights and advocacy, like CAFA, the Lebanese feminist organization, and also Asfar Institute, who are working for the gender equality and empowerment of women and girls, and the fight against all forms of violence, and also integrating abortion advocacy in their new norms. So, this is Maramet. It's our hope to have this regional network spreading our voices, and trying to act all together and collaborate and change experience and reinforce our capacity to advocate. Thank you very much.
Konferansı hazırlarken ben şahsen yani Tunus üzerine böyle araştırırken çok şaşırmıştım. Kürtaja dair durumun hani biricikliği, ayrıksı bir yerde duruyor olması bölge açısından da soru cevaplarla da belki açabiliriz Tunus'un neden gerçekten böyle bu hem bölgede ayrıksı yerde durması hem de sosyopolitik olarak da hani enteresan. Dolayısıyla Tunus'u doğrudan senden duymak çok güzel oldu. Çok teşekkürler tekrar katkın için. Şimdi son olarak da Women on Web'den Veronica ile devam edeceğiz. Veronica hem aslında Women on Web neler yapıyor onu anlatacak hem de globalde haplarla kürtaja dair durum nedir? Biraz böyle globale dair küreseldeki duruma bir fotoğraf çekecek. Women on Web'i eğer bilmiyorsanız neler yaptığını özellikle kulak vermenizi tavsiye ederim. Son derece ilham verici, muhteşem işler yapılıyor. Çünkü gerçekten böyle ufuk açıcı derler ya, yani kelimenin tam anlamıyla öyle çünkü. Şimdi sözü Veronica'ya veriyorum.
My name is Veronica Fernandez and I'm the operations manager at Women on Web. That is an organization that for 20 years has supported access to abortion pills online. And our work sits at the intersection of these topics that I will be talking today, like abortion medication, medical guidelines, research, self-managed abortion, activism. So I will be talking about those concepts today, providing some international context as well. And then later on in the presentation, I will talk more about the work of Women on Web. Just to start briefly about how abortion looks like worldwide. So every year around 73 million abortions take place worldwide. That means that 1 in every 4 women will have an abortion at some point in their life. So when abortion is criminalized or when there are barriers to access, that doesn't stop people from having abortion, just push them to have them under less safe or unsafe conditions. And unsafe abortion is a major public health issue, and it remains one of the leading causes of maternal mortality and morbidity around the world, and being this entirely preventable. So unsafe abortion also places a burden in health systems, of course. And as it has been mentioned, I will be mentioning as well like international health and human rights bodies like the WHO, the SEDA Committee, the United Nations Human Rights Committee. They have called for the criminalization of abortion. So, and in this landscape, abortion pills came to change everything. They are revolutionary. They are transforming how women access and experience abortion. So they have transformed the landscape worldwide. So in restrictive settings, these medicines have dramatically reduced maternal mortality and morbidity because women have been able to have a safe abortion despite the law being whatever it is. So they have also lower barriers to in-clinic care because people can self-manage their abortion. I will talk more about that later. But the benefits of using the pills goes even farther. Like they offer autonomy, allow people to make decisions of their own bodies. They offer privacy because they can be taken at home. They also provide control because they let people decide when and how to have the abortion. And in many ways also the process is more natural because it resembles a natural miscarriage, but no option is better than other regarding surgical or medical. But what is clear is that more options equal better access. Just briefly about what is abortion, because we have talked about it today multiple times, but it's these two medicines, mifepristone and misoprostol. They were both discovered around the 80s, misoprostol because of Brazilian women using it. This is a medicine that it is for stomach issues, and they read in the instruction not use if you're pregnant, so they start using it to cause an abortion, and then mifepristone was discovered in France in the 80s as well. And when used together, of course, these medicines cause an abortion in 99% effectiveness. And what I mean with this as well is because it was discovered in the 80s, there are now decades, 40 years of scientific research showing how abortion pills are safe, effective, and highly accepted by the users. And up to 13 weeks of pregnancy, it can be safely used at home, following instructions. And this has opened the door to new models of care, self-management, and telemedicine, as we have been mentioning today as well. Just briefly, we have talked about the WHO guidelines and the guidelines, the very relevant guidelines of 2022. The mifepristone and misoprostol were included in the list of essential medicines. This was mentioned today as well in 2005. This list of medicines means that these medicines are fundamental for a functioning health system. And then in the guidelines of 2022, it clearly states that self-managed abortion, including through telemedicine, can be used up to 13 weeks of pregnancy. But these approaches are not only supported by the WHO, but also endorsed by leading professional organizations like FIGO, that is the International Federation of Gynecology and Obstetrics, who represent societies of obstetricians and gynecologists in over 130 countries, or the NAF, the National Abortion Federation in North America. So what is self-managed abortion? When we talk about self-managed abortion, what do we mean? Because so we like to say that self-management is a spectrum. So this means, as Rodica was mentioning before as well, like people doing the abortion might manage some part of the process or the whole process without the direct involvement of a healthcare provider. And the process is divided like in assessing eligibility, taking the medicines, and assessing completion. And according to the WHO in the 2022 guidelines, they included that it's possible for people to manage their own abortion partly or completely as soon as they have accurate information, quality medicines, and the option to seek care if needed. That's all. In practice, in reality, most people will fall somewhere in this spectrum, of course, depending on their context and what they have available to them. So, for example, in some legal settings, you might have access to medication abortion, but you are forced to take it in the clinic, or you must have an ultrasound mandatorily. While in other contexts, telemedicine is fully implemented and you can take the medicines at home without visiting a clinic. In restrictive settings, so some people might self-manage their own abortion, getting the pills online, getting the information online, and that's it. Other people might contact activist groups or accompaniment groups to guide them and to help them through the process. So that the key point is that abortion pills provide the possibility of this spectrum, increasing a lot accessibility. And people, it has been mentioned before in the studies that my colleagues have presented, but they might choose to manage their own abortion for many reasons. Some, of course, because logistical and legal barriers, so there is the only option. But also, it allows individuals to be in control of their bodies and the process on their own terms. So in a way that fits their needs and circumstances. So what is the role of the healthcare provider? So as I mentioned before as well, and in the WHO care guidelines, it says clearly, like, there is no need for direct involvement of a healthcare provider in the first trimester. So this shift abortion care away from being something that must happen under medical supervision to something that can safely happen in people's own hands, with health professionals acting then as supportive allies rather than gatekeeping. And this shift is not simple, of course, because it challenged these medical hierarchies that have long defined how care is delivered. And we know that this is not the case in many countries. So another key aspect that the WHO include in these guidelines is what they call task shifting or task sharing. It has also been mentioned that it's expanding who is allowed to provide abortion care. So expanding which professionals. So in many countries this is happening already. In some, of course, it's only the gynecologists who are authorized to perform abortion. This creates huge bottlenecks and unnecessary barriers. But that is starting to change in many countries, and other countries are moving in this direction as well, like Sweden, France, Netherlands, US. Can be now be provided the abortion by midwives, family doctors, nurse, or other trained professionals. So this helps to lower barriers and also overcome geographically inequalities for people that live, for example, in rural or remote areas. But what about ultrasound and confirmed pregnancy? What about pre-abortion care and post-abortion care? Like Dr. Rodica was also talking about it, right? Like in the first trimester, people can totally self-assess their gestational age by knowing the date of their last menstrual period. In clinical exam, ultrasound is not required in most early pregnancies. And after taking the pills, the same, they can self-assess the completion with the proper information, either by recognizing their symptoms that work or with some pregnancy tests some week after. But routine follow-up visits are not needed after an abortion. However, care should be available in case of somebody require or needed. Similarly, the WHO guidelines also mention about post-abortion contraception and counseling be offered on request, not as an obligation. So overall, these guidelines recognize that with the right tools, people can safely manage, can safely self-assess eligibility and completion. With the health system, should focus then on creating an enabling and supporting environment that trusts individuals and ensures access to care when they need it. Yet that's far from the reality in most countries, but that's the direction we should aim for. And looking about telemedicine and online abortion care, so of course telemedicine and online abortion care is this care that happens remotely, in which the person has a consultation or remotely and the pills can be sent by post. This model began to emerge in the middle 2000s, led by activist research-based initiatives such as Women Web, the organization I work for, who was the first international online abortion service. And these services, online international abortion services, became a lifeline for people who needed abortion in restrictive settings. And over time, this was 20 years ago, right? So over time, evidence and research have also confirmed the safety and effectiveness of this approach. Then it came the COVID pandemic, that it has really been a major turning point regarding telemedicine and medication abortion, because when lockdowns happen and the clinics close, and so several governments in different countries introduced as a temporarily measure telemedicine for abortion, allowing these consultations to happen remotely and getting access to the pills. And that lowered the barriers to access, and because of that, several countries later on decided to make these measures permanent and part of their healthcare systems, no longer just as an emergency measure. I will put the example of the UK as well. The main abortion provider in the UK is Bypass, and after the 2 years that was the pandemic, they wanted to remove the option of the telemedicine, but they did a public consultation, and they were the main defenders of telemedicine remaining as an option. They actually built a document. They have a document online that is really good because they explain all the barriers that they are overcome thanks to telemedicine and all the benefits that it has. I recommend to read that document that they created. So among these benefits that it offers, that some of them have been mentioned today as well, it lowers barriers because people don't need to travel longer distance, avoiding this geographical discrimination. You don't need to take time off work because with the pills in your hand you can decide when to take it. You can take it in the weekends or whenever you don't work. You don't need to find childcare. You don't have to face the stigma that it comes with sometimes visiting a clinic. And it improves equity as well because it reaches those in those remote or restrictive settings where in-person services might not exist at all, even if it's a country where abortion is illegal. And it supports autonomy because it provides this person-centered care in which people can manage their own their abortion in their homes and in their own terms. And of course it lightens the health system loads as well because uncomplicated abortion do not require any in-clinic visits. So today, worldwide, medication abortion it's the most common abortion method in many parts of the world. In the United States, it's over 60% now, and that's only counting blue states that allow abortion. And we see similar trends in other countries like the UK, France, and across Latin America. So now online hybrid models are become mainstream and also are endorsed by WHO and other professionals. I won't talk much about activism and community support. We have already had the amazing example of socorristas, but I will highlight again how when abortion remains restricted or with barriers to access, activists and accompaniment networks play a crucial role. So across Latin America, but also Africa, Asia, and beyond. These feminist group and grassroots collectives have been supporting people to self-manage their abortion. So they provide what laws and health system have failed to provide, maybe information, direct access to the pills, accompaniment to these people. So, and as has been said, as we know, you have the example of Turkey, even when abortion is legal, there are gaps in access and there are needs to organize groups to fill these gaps. Like otherwise nobody is going to do it. And just briefly, about the work of Women on Web. So Women on Web is a feminist organization that facilitates access to abortion pills online. The service was launched in 2005, so 20 years ago. And it was the first international service of abortions by post. Our work is divided in 3 pillars of work: provision, research, and outreach. So the first one is provision, so our telemedicine service, like people can complete a consultation online, and once it's reviewed, their pills are shipped to their address. We request donations, but if people cannot donate, the service is provided regardless. So in these 20 years, we have supported over 130,000 people to receive abortions via us. And our support goes beyond providing the medicines. We also provide access to critical information. This includes guidance on how to use the medicines for people who already have them, or referrals to other organizations. So our service is tailored in different legal and cultural contexts and supported by a help desk that works in 16 languages. And we work 365 days a year. Another key pillar of our work is research. Since we were founded, so we have generated robust data demonstrating safety, efficacy, and acceptability of medical abortion. this has been instrumental in advancing access to abortion care. For example, our findings were used on the debate of legalization of abortion in Ireland, or show that the outcomes of telemedical abortion is similar to in-person care. And of course, in 2020, when the pandemic happened and many countries started including this this model in to provide abortion, so our research was there to support those models. They started doing what we were doing for 15 years. And our third pillar of work is outreach. We do partnerships, of course, with local organizations to expand abortion care, especially in restrictive and neglected contexts. And our outreach also focus on challenge internet censorship. That is something that I will mention later a bit. I just wanted to briefly mention about demedicalization is something that we have talked about, and I would like to talk about how Women on Web is also in a demedicalization journey. Because Women on Web started 20 years ago, and a lot has happened since then. So over the past few years, we have undergone the deep transformation that we call our demedicalization journey. So for our first 15 years, we were a physician-led organization, telemedical service, focused on demonstrating that abortion pills are safe and effective. And this mission was important. It had to be that way. It helped generate evidence that now supports WHO guidelines, national guidelines. But once that goal was achieved, we start to ask ourselves, like, how much medical control is necessary for people to have safe abortions? So we have started re-examining every part of our model, our language, our protocols, our internal structures, to reduce this unnecessary medical gatekeeping and build a service that is based on trust, autonomy, and feminist values. We have, for example, removed questions in our consultations that were reinforcing medical control instead of we are changing to focus on information and choice. We are also building stronger alliances with feminist and accompaniment networks. And we have, for example, expanded our model to provide what we call advanced provision, that is providing the medicines before you get pregnant to have them on your health box. Internally, we have also demedicalized our leadership, so our director is not a physician anymore, and our physicians, because we have physicians in the teams, but they now act as advisors, not as gatekeepers. So our journey isn't finished. Of course, this is a continued process of learning and reflection, but it's ones that move closer to a world where abortion care is accessible, person-centered, and grounded in trust and autonomy, rather than control. So we are trying to dismantle these medical hierarchies that I talked before in our own service. And lastly, I will talk a bit about the challenges that we faced as an online abortion care service. And that main challenge is censorship. So, and it's a growing threat in abortion access worldwide, in a time where information is moving basically more and more to be online. We have seen this increase of censorship in the last 10 years. At Women on Web, for example, our website is currently censored in 8 countries, being one of them Turkey, I think that was mentioned before as well. To overcome these barriers, we create, for example, mirror websites, but which often get blocks as well. Like, for example, in South Korea, our mirror website have been blocked like 4 times already. I will mention briefly about the case of Turkey. In June of 2018, despite abortion being legal in Turkey, but a Women on Web website was blocked following the administrative decision of the Turkish Medicines and Medical Devices Agency. So we were not provided any sort of warning or notification. It was directly blocked under a law that prohibits the promotion and sales of off-label drugs or similar medical preparations. So what we do is a strategic litigation as well. We are doing this in several countries where our website is blocked. So in the case of Turkey, in collaboration with the Freedom of Expression Association, we challenged this decision in court. The court dismissed our case, ruling that it should remain blocked. We appealed, but it was also dismissed. But we continue, like we don't stop the court case. We take them to other bodies, legal bodies if needed. So in February of 2023, we presented an application to the Constitutional Court in Turkey. But that's still ongoing. This legal case takes forever. But fortunately, one sad thing is that website censorship works. It's one of the most effective tools used to suppress abortion information and restrict access to care. And at the same time, it's not only the website, but it's also social media platforms that are removing abortion content, shadow banning accounts, violating free speech. So the impact is serious because it affects both abortion seekers and abortion providers, because we depend on a free and open internet to access this life-saving information. So websites being blocked, it does not only silence advocacy, it silences access to essential healthcare. So we also believe that we need to work collectively on this. That's why we take it also as a big role in our outreach, to protect the digital space as part of reproductive rights. This is just some examples of our content being suppressed again and again on social media. And yes, some brief takeaways. Abortion pills are safe and effective and evidence-based. They transform how people access and experience abortion worldwide, with decades and decades of research proving how safe they are. Self-managed and telemedicine abortion expand access, but also equity and autonomy, up to 13 weeks, endorsed by the WHO. Then activists, feminist networks, and digital services like Women Aware are reshaping abortion access and care through community, digital innovations, and research. And yes, the final note that we should protect online access to information, because it's essential to safeguard bodily autonomy and reproductive rights. Yeah, thank you.
Çok teşekkürler Veronica.